When your heart finally sends a warning, it's often already too late. You can look fit, you can run 10 kilometers without stopping, you can feel stronger than you did 10 years ago. But a dangerous blockage could be quietly growing inside the arteries that keep you alive. No pain, no shortness of breath, no obvious red flags. How is that even possible? Because human biology is brutally efficient at one thing: adaptation. Your body is so good at compensating that it can hide a severe coronary blockage for years, sometimes decades, while blood flow appears completely normal. And that uncomfortable reality explains a chilling statistic. For many people, the first symptom of coronary heart disease is not chest pain. It is sudden cardiac death. In this video, you're going to understand why a healthy heart can suddenly fail, how dangerous plaques grow silently inside the arteries, and most importantly, what actually works if you want to detect risk before disaster strikes. Let's start from the beginning. Your heart is not just another muscle, it is one of the most metabolically demanding tissues in the entire human body. Every minute of your life, it must contract, relax, and pump blood to trillions of cells without pause. To keep up with that workload, the heart depends on its own dedicated fuel lines, the coronary arteries. These vessels wrap around the surface of the heart like the roots of a tree gripping soil. Their job is simple but absolutely critical: deliver oxygen-rich blood to the heart muscle itself. There are two main coronary arteries: the right coronary artery and the left coronary artery. The left quickly branches into a particularly important vessel called the left anterior descending artery, often abbreviated as the LAD. Clinically, this artery has a grim nickname: the Widowmaker. The reason is pure anatomy. The LAD supplies a large portion of the left ventricle, the chamber responsible for pumping oxygenated blood to your entire body. If blood flow through this artery stops suddenly, the heart's main pump begins to fail within minutes. But here is the question that confuses many people: how can someone who exercises regularly still develop a dangerous blockage? The answer begins at the microscopic level of the artery wall. A healthy artery is flexible and smooth, almost like a brand new rubber hose. The inner lining, called the endothelium, normally allows blood cells to glide through with minimal friction. Under ideal conditions, this surface behaves almost like a non-stick coating. But real life is not ideal. Over years and decades, several factors gradually damage this delicate inner lining. High blood pressure creates mechanical stress. Elevated blood sugar promotes inflammation. Smoking introduces toxic chemicals that directly injure the vessel wall. Even chronic metabolic stress from poor sleep, obesity, or persistent systemic inflammation can contribute. At first, the damage is microscopic, far too small to feel. But your body immediately attempts repair. LDL cholesterol particles begin to accumulate at these injured sites, acting almost like biological patch material. Then the immune system steps in. White blood cells migrate into the vessel wall and ingest the trapped cholesterol. Over time, these cells transform into what are called foam cells. As this process continues, layers of fat, inflammatory debris, and calcium begin to build up inside the arterial wall. This slow, progressive process is known as atherosclerosis. Now, here's the misunderstanding that misleads millions of people. Most people imagine plaque buildup like hair clogging a drain. The pipe gets narrower and narrower until blood flow gradually decreases and symptoms appear. Logically, that makes sense. Biologically, that is often wrong. In many cases, as plaque accumulates inside the artery wall, the vessel compensates by expanding outward. This phenomenon is known as positive remodeling. Instead of immediately narrowing the internal channel, the artery stretches to preserve blood flow. You can have significant plaque load, while standard blood flow still appears normal. You can pass a stress test. You can feel perfectly fine. You can even perform intense exercise. This is why many heart attacks occur in people who never experienced classic warning symptoms beforehand. So, what actually turns a silent plaque into a life-threatening emergency? The key factor is not just size, it is stability. Inside the artery wall, plaques come in different forms. Some are heavily calcified and relatively stable. Others are soft, lipid-rich, and covered by a very thin, fibrous cap. Think of that thin cap like the surface of a fragile blister. As long as it remains intact, blood continues to flow. But a sudden spike in blood pressure, intense physical exertion, severe emotional stress, or systemic inflammation can rupture fragile cap. When it ruptures, everything changes within seconds. The inner contents of the plaque are suddenly exposed to circulating blood. Your body interprets this as an acute injury and immediately activates the clotting system. Platelets rush to the site and begin forming a thrombus, a blood clot. This response is life-saving when you cut your skin, but inside a coronary artery, it can be catastrophic. The clot can rapidly enlarge and completely obstruct the vessel, suddenly stopping oxygen delivery to part of the heart muscle. This is the classic mechanism behind many acute myocardial infarctions, heart attacks, and the timeline is very short. Within about 20 minutes of severe oxygen deprivation, heart muscle cells begin to suffer irreversible injury. Around 90 minutes, large areas of tissue can become permanently scarred. Scar tissue does not contract and pump. That is why in cardiology there is a phrase repeated constantly: time is muscle. Now there is another scenario that deserves attention, especially among highly active individuals. Not all heart attacks require a fully blocked artery. Imagine a person with a moderate having 50% coronary narrowing. At rest, this may cause no symptoms at all. Blood supply is still adequate for baseline needs, but during intense exercise, the heart's oxygen demand skyrockets. Heart rate climbs, contractility increases, the myocardium requires dramatically more blood flow. If the partially narrowed artery cannot meet that increased demand, the heart muscle enters a state called ischemia, essentially oxygen starvation. This mismatch between supply and demand can still produce measurable heart muscle injury, even without a total blockage. Certain conditions can worsen this imbalance. Rapid arrhythmias, such as atrial fibrillation, can shorten the heart's filling time. Severe anemia reduces oxygen carrying capacity. Extreme dehydration lowers circulating volume. Here is another important clinical threshold. Many people do not experience classic exertional chest pain until a coronary artery is roughly 70% narrowed. Below that level, the body often compensates remarkably well. But paradoxically, many dangerous plaque ruptures occur in arteries that were less than 50% blocked beforehand, because softer plaques are more prone to rupture than large, heavily calcified ones. This is why relying purely on symptoms can be misleading. Now, there is some encouraging news. Your heart is not completely defenseless. Over time, especially with consistent aerobic training, the body can develop collateral circulation, tiny alternative blood vessels that act like natural bypass routes around partially blocked arteries. Think of them as side streets forming when a highway is chronically congested. These collateral vessels can sometimes reduce the severity of damage during a coronary event. Regular moderate-intensity aerobic exercise appears to promote this adaptive vascular growth. High-intensity interval training may also contribute when performed appropriately. But let's be very clear. Collateral vessels are helpful. They are not a guarantee. Which brings us to the most practical question. If dangerous plaques can hide silently, how do you actually determine your risk? Standard blood tests as cholesterol panels, glucose levels, inflammatory markers are useful. They tell you about risk factors circulating in your bloodstream, but they do not directly show whether plaque is already embedded in your artery walls. For structural insight, imaging matters. One widely used tool is the coronary artery calcium score. This is a quick CT-based scan that detects calcified plaque in the coronary arteries. A CAC score of 0 suggests very low short-term risk. Higher scores, particularly above 100 or 400, indicate progressively greater plaque burden. However, CAC primarily detects hardened, calcified plaque. It may miss softer, earlier stage plaques. For more detailed visualization, coronary CT angiography can identify both calcified and non-calcified plaque and evaluate the actual vessel lumen. It provides a more comprehensive anatomical picture, though it is not necessary for everyone. The key takeaway is simple but powerful. Do not assume absence of symptoms equals absence of disease. If you have significant risk factors, family history of premature heart disease, long-standing diabetes, uncontrolled hypertension, smoking history, or metabolic syndrome, discussing appropriate screening with a qualified clinician is a rational step. Now, before we finish, let's talk about what you can control. While genetics play a role, the progression of atherosclerosis is strongly influenced by modifiable factors. Maintaining healthy blood pressure reduces mechanical stress on the arterial wall. Keeping blood glucose in a normal range limits glycation and inflammatory damage. Avoiding tobacco exposure prevents direct endothelial injury. Regular aerobic activity improves vascular function and metabolic health. Adequate sleep and stress management help regulate systemic inflammation. None of these are instant fixes, but together, over years, they meaningfully shift cardiovascular risk. And one final point that could save a life. Classic heart attack symptoms are not identical in everyone. Many men experience the well-known pattern: heavy chest pressure, pain radiating to the left arm or jaw, cold sweating. Women, however, more frequently present with subtler signs: unusual fatigue, shortness of breath, nausea, upper back discomfort, or what feels like severe indigestion. Because when it comes to heart muscle, delay is damage. Don't forget, this video is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always consult a qualified healthcare provider with any medical concerns. If this video helped you understand what's really happening inside the coronary arteries, share it with someone who still believes feeling fine always means being healthy.